Ladies and gentlemen, welcome to today's lecture. Today we are going to talk about revascularization in patients with stable ischemic heart disease from a guidelines perspective.
Let's see what have changed in the new ACC 2021 revascularization guidelines. In summary, studies have shown that CABG confers a survival benefit over medical therapy in multiple subsets of patients, including those with left main coronary artery disease, triple vessel disease, and ischemic cardiomyopathy. Many of these studies were conducted before the widespread use of antiplatelet and statin therapies and before the broad recognition of benefits from beta blockers and AC inhibitors, ARBs. However, there are no RCTs that have demonstrated a survival advantage of PCI over medical therapy in patients with stable ischemic heart disease. There may be an advantage of PCI over medical therapy in patients who have a clinical indication for CABG but are deemed prohibitive surgical risk. For this reason, the heart team must weigh the risks and benefits of PCI as compared to medical therapy in such patients. The ISCHEMIA trial randomized patients with stable ischemic heart disease and moderate to severe ischemia on stress testing to an initial invasive strategy versus an initial conservative strategy. Patients with left main disease or an ejection fraction less than 35% were excluded from enrollment. As compared with a strategy of medical therapy alone, an invasive strategy including revascularization with PCI or CABG was not associated with improved outcomes. Important data has been extracted from this trial, and these guidelines have adopted recommendation based mostly from the results of ischemia trial. Similar to the older guidelines, in the new guidelines, we will discuss revascularization under three headings: to improve survival, to improve symptoms, and to prevent the occurrence of adverse cardiovascular events. First, let's talk about revascularization to improve survival in stable ischemic heart disease compared with medical therapy. The first subset of patients who are going to have a survival benefit with revascularization are patients who have left ventricular systolic dysfunction and multivessel coronary artery disease. We will divide these patients into two subsets. The first subset are patients with severe left ventricular systolic dysfunction, that is, their ejection fraction is less than 35%. And if their anatomy is amenable to CABG, these patients should undergo CABG, and this is a class 1 recommendation for this subset of patient. On the other hand, if the patient has mild to moderate left ventricular systolic dysfunction, that is, their ejection fraction is between 35 and 50%, as well as multivessel coronary artery disease, appropriate anatomy for CABG, then CABG is a 2A recommendation for those patients. Patients with left main vessel disease are another group of patients who will have a survival benefit with revascularization. And there are two recommendations for these patients. The class 1 recommendation is that in patients with stable ischemic heart disease and significant left main stenosis, CABG is recommended to improve survival. On the other hand, in selected patients with stable ischemic heart disease and significant left main stenosis for whom PCI can provide equivalent revascularization to that possible with CABG, PCI is reasonable to improve survival. These basically are the two subset of patients who will benefit the most as far as survival is concerned with regards to revascularization. The other group of patients, for example, patients with multivessel coronary artery disease, and we know that in the previous guidelines there were class 1 recommendation for these patients. These recommendations now have been downgraded to 2B, and what these recommendations are telling us is that in patients with stable ischemic heart disease who have normal ejection fraction, significant stenosis in 3 major coronary arteries with or without proximal LAD, and anatomy suitable for CABG, CABG can be performed, and if the anatomy is suitable for PCI, then the effectiveness or the usefulness of PCI in such patients is unclear and uncertain. The other subset of patients are those with stenosis in the proximal LAD artery. There was very much interest with regards to patients with stenosis in the proximal LAD artery, that they should be revascularized ASAP because it was considered as a left mains equivalent. Now, the current guidelines state that in patients with stable ischemic heart disease and normal left ventricular ejection fraction and significant stenosis in the proximal LAD artery, the usefulness of revascularization to improve survival, in particularly if the ejection fraction is also normal, is uncertain. And finally, patients with single or double vessel disease that doesn't involve the proximal LAD artery. And this has now been given a class 3 recommendation. Either there is no benefit or there is harm, particularly in patients with one or more coronary arteries without significant stenosis. Before moving into the next slide, I will take a minute or two to discuss why the class 1 recommendation for the multivessel coronary artery disease was downgraded to 2B. This reflects a new evidence showing no advantage of CABG over medical therapy alone to improve survival in patients with 3-vessel CAD with preserved left ventricular function and no left main disease. The older recommendations were based on evidence from registry studies, a meta-analysis, and a single RCT, all of which were completed more than 20 to 40 years ago, before the development of new surgical techniques or advances in medical therapy associated with improved prognosis. Newer evidence from the ISCHEMIA trial and from meta-analysis which incorporated or did not incorporate the ISCHEMIA results, as well as a more detailed review of earlier studies, supported this downgrade. The second goal of revascularization in patients with stable ischemic heart disease is to reduce adverse cardiovascular events. Clinical practice guidelines have traditionally included recommendation for revascularization in patients with stable ischemic heart disease based on the ability of CABG or PCI to improve overall survival or to reduce ischemic symptoms as compared with medical therapy alone. However, there are other clinical events that can affect a patient's overall prognosis and that remain important consideration for patients. Several studies suggest that revascularization with CABG or PCI lowers the risk of adverse events such as cardiac death, MI, or urgent revascularization compared with medical therapy alone. This is basically a new recommendation. It is a class 2A recommendation which states that in patients with stable ischemic heart disease and multivessel coronary artery disease, appropriate for either CABG or PCI, revascularization is reasonable to lower the risk of cardiovascular events such as spontaneous MI, unplanned urgent revascularization, or cardiac death. The third goal of revascularization is to improve symptoms compared to medical therapy. One of the main goals of coronary revascularization with either PCI or CABG surgery is to improve symptoms. In the treatment of patients with stable ischemic heart disease, medical therapy can often be an effective option. However, studies have shown that revascularization results in a greater improvement in angina or quality of life than does medical therapy alone. Additionally, some patients may be intolerant of or unwilling to take anti-anginal medications. For these reasons, revascularization is frequently used to provide symptom benefit. There are two recommendations for these patients. The class 1 recommendation is that in patients with refractory angina despite medical therapy and with sufficient coronary artery stenosis amenable to revascularization, revascularization is recommended to improve symptoms. The class 3 recommendation, patients with angina but no anatomic or physiological criteria for revascularization, neither CABG nor PCI should be performed because inappropriate revascularization of non-obstructive plaques with CABG can lead to progression of underlying coronary artery disease. An inappropriate use of PCI can cause periprocedural MIs and would not be expected to improve quality of life or anginal symptoms. Let's briefly talk about revascularization for patients with complex coronary artery disease. Revascularization with either CABG or PCI is indicated to treat symptoms or improve outcomes in specific subsets of patients. However, CABG and PCI are inherently different in mechanisms by which they improve blood flow to the jeopardized myocardium. PCI will directly relieve a discrete obstruction and increase the arterial lumen in the stenosed area, but will have no effect on preventing plaque progression or rupture in other disease segments within the artery. In contrast, bypass of a coronary artery will improve blood flow to the jeopardized myocardium supplied by the diseased artery and will also protect the distal myocardial beds from future ischemic insults caused by proximal plaque progression or rupture. Although most studies comparing CABG and PCI have reported similar survival benefits, certain subgroup of patients have been shown to derive a survival benefit from CABG compared with PCI. Additionally, compared with PCI, CABG may be more effective at reducing the risk of late spontaneous MIs. The two recommendations for these patients are Class 1 recommendation, which states that in patients who require revascularization for significant left main coronary artery disease with high complexity coronary artery disease, it is recommended to choose CABG over PCI to improve survival. And the evidence for this recommendation is from the Sentex trial. Class 2A recommendation states that in patients who require revascularization for multivessel coronary artery disease with complex or diffuse CAD, that is their Sentex score greater than 33, it is reasonable to choose CABG over PCI to confer a survival advantage. This was all for today. Thank you for your attention. If you have any questions, please post them in the comment section. I will try to answer them ASAP. And I will also request you to please consider liking, sharing this video, subscribe to the channel. This will be a great boost for us. Thank you.